Hello, my name is Diwakar Kinra, and I'm an endodontist in private practice in Flint, Michigan. In our first webcast, we discussed the importance of philosophy, education, and practice lifestyle as we begin our career in dentistry. We will now continue our web series on how to provide more quality endodontics to establish your practice in hopes of widening your scope of dentistry, building your practice, and increasing your ability to be a more profitable and successful dentist. In our last segment, we discussed case selection and how it is linked to profitability in performing well-done, painless root canal procedures in your office. And that depends on how you choose the proper case to make this a reality. Once we have selected a proper case to make you look like a rock star, and which will show your talents as a dentist and allow you to exceed your patient's expectations, it's time for diagnosis. But before we get into the logistics of that, let's take a look at this common phenomena, as many of you can empathize with what I'm saying. Doc, it never hurt till what? You placed that crown, took that amalgam out, or replaced that filling, or did that restoration. I hear that a lot when people come into my office. And I think as dentists, we need to do a better job at informed consent and diagnosis when it comes to restorative work. What do I mean by that? Depending on what school you went to, there are certain departments that really influence you as a dentist. In my case, it was the periodontal department. Why do I say that? Well, I had a periodontal class from the moment I entered school until I left. I had practiced general dentistry when I left school, and I saw that many general dentists do a great job charting our patients as far as restorative, edentulous, oral cancers, prosthetics, and especially periodontics. We chart every tooth in the mouth up to 6 points per tooth, but rarely do we chart the endodontic health of the tooth. This is critical when it comes into play for treatment plan. There needs to be an endodontic diagnosis on every tooth that we're going to do major restorative work before treatment. Now let's take a look at an example that shows the basics. If we assume that your practice has 1,000 patients and that the average patient only has even 20 teeth, that's 20,000 teeth. If we misdiagnose even 1% of these teeth, that's 200 teeth. And even if you assign any fee to that root canal procedure, there is additional income missed in your office. Now, I am not using this chart to encourage over-treatment. Our goal as healthcare provider is to always do no harm. But how many times can we save ourselves if we just perform simple diagnostic tests to allow us to perform treatment in the proper chronological order? Diagnosis in general has some very solid concepts that we have not changed in years within the field of dentistry. The main objective in diagnosis is to 1, reproduce the chief complaint, 2, determine the cause of the chief complaint, and 3, eliminate the cause of the chief complaint. Some things have not changed in dentistry, such as our systematic approach in diagnosis for each and every case. The SOAP format, which stands for subjective, objective, assessment, and plan of action. In reality, this is a story that is comprised of 2 sides. Subjective. This is what I refer to as the patient side of the story. It consists of an interview with the patient that allows you to comprehend what they are feeling. To perform this interview correctly, you need to ask information-filled questions. To begin, you need to go over the medical history with the patient, as many medicines or medical conditions may mask or mimic dental-type pain. After that review, there are the first 4 questions that need to be answered about chief complaint. And that is the history of the pain, which stimulus brings on the pain, meaning something thermal, biting, percussion, or no stimulus, the severity of the pain, and by this I mean I want the patient to give me a numerical number associated with the pain on a scale from 1 to 10. This helps me quantify the pain for future reference, and that pain is such a subjective feeling, meaning one person's 5 may be another person's 8. And next would be the frequency of pain. After we have conducted the patient interview or subjective side of the diagnosis, it's now time to get our side of the story, which is the objective portion of the SOAP format. And this is inclusive of 1, a clinical exam. This is something that most dentists are very comfortable with. 2, radiographic assessment, where we take radiographs from several angles to help us determine what could possibly be the source of pain. And then finally, 3, comparative testing. Testing for thermal sensation, biting and percussion pain, to name a few. Many of us seem to think that this is the only portion that counts, but that is a very large misconception when it comes to thorough diagnosis. For a more thorough webinar on diagnosis, find the lecture by Dr. George Bruder that has a fantastic review on all things diagnosis, or others at chairtime.com. Now that we have gathered both sides of the story from the patient and our own observation, it's now time to come up with an assessment. That will include a pulpal and periapical diagnosis. And there is also the possibility that the diagnosis could lead us to a non-endodontic factor that may be causing the chief complaint. Once we have come to our conclusion, we then have to come up with a plan of action that is satisfactory to our patient. And if endodontics can resolve the chief complaint, we as dentists are in the business of saving teeth and should proceed with root canal therapy. Remember, for those of you that are quick to judge and think that reproducing the chief complaint isn't important, this slide is symbolic of what not to do as an astute clinician. I am sure that this patient is still in pain and that their chief complaint was never resolved. That brings us to what's in store for the future. And this is where the future of diagnosis is headed. CBCT, cone beam computed tomography. This is the virtual microscope of diagnosis. As you can see here, CBCT allows for a much more informative radiographic interpretation of the patient's current status than what was ever available before. This information will allow us to give a more succinct plan of action for the patient. Thank you again for allowing me to share this information with you. Join me in our last session for a very unique discussion on case acceptance. This is a very important topic as more patients are becoming well educated on their choices and expect you to guide them. In the end, the most difficult part of the treatment may be getting the patient to agree to it. And our last webcast really has great information on getting you to help the patient say yes. Thanks again, and until next time, I am Diwakar Kinra, and it's been a pleasure sharing this information with you.